on to the next session, which is an interesting case presentations by students. And for that, I'd like to hand over the dais to the moderators, Dr. Sunil Narayan and Dr. Majaz Munis.
Hi, good evening. Thank the Indian Stroke Association, especially here in this year's summer school meeting led by Dr. Padma and Dr. Rohit for once again organizing yet another very interesting stroke summer school proceedings. Here I am co-chaired by a very respected colleague who is well known to all of you in the stroke scenario abroad as well as in India, Dr. Majaz Munis. And Dr. Majaz, you have to say anything specific before we start?
I'm honored to be part of the first meeting that I have attended for the summer school, and it promises to be an interesting case. And thank you for joining us and for your kind words.
Yeah, so today's the first case presentation. This is something which the summer school has always been doing, which draws a lot of interest from the neurology and the stroke students. So there is a very interesting case presentation from CMC Ludhiana to kickstart this student presentation. And CMC Ludhiana is the stroke team is led by Dr. None other than Dr. Pandian, and we look forward to this interesting case presentation from Dr. Deepthi. I guess she's either a neurology resident or a stroke fellow.
Yes, I'm a final year.
Yeah,
I'm a final year neurology resident.
All right, yeah. So I think you can go ahead, please.
So I'll share my screen.
So maybe I think after your case presentation, before you give the clinical, so you could ask some questions to the resident before you. So you could ask some questions. Yeah, different level before you go to the diagnostic aspects. You could ask questions and get the feedback and then proceed. That will make it a bit more interesting. That was the suggestion from Dr. Majaz, my colleague as well.
Okay, yes. Shall I start, sir?
Yes, please. Yes.
Good evening, respected faculty and delegates. I'm Deepthi, final year resident from CMC Ludhiana, going to present a case of a 45 years old lady who's a resident from Ludhiana who presented sudden onset weakness in left upper limb and lower limb, which was associated with facial deviation towards the right and slurring of speech, with no history of loss of consciousness, headache, or diplopia, with no previous history of TIA or stroke. She was not known to have any vascular risk factors and no family history of stroke or cardiac disorders. She did not have any history of deep vein thrombosis or any past history of connective tissue disorders, no recent or past history or GI bleed or head trauma. She presented to our emergency department within 1 hour and 35 minutes since the onset of the symptoms. Coming to the examination, her GCS was 15/15 with a heart rate of 102 beats per minute, which was irregularly irregular, low volume pulse, and all the peripheral pulses were palpable, and there was no carotid bruise. PP was 160/80 millimeter of mercury in the right arm supine position with saturation of 100%. NIHS score at presentation was 11, and the significant examination on cardiovascular system examination was a variable S1 with a mid-diastolic row numbing murmur, which was heard best at the apex without any pre-systolic accentuation present. So our clinical diagnosis is...
Yeah, I was thinking you could give a toss to the audience, students participating. What would be the first diagnosis? Just give a 5 to 10 seconds and then go to your examination. That's what we are suggesting at every level.
Okay.
So maybe you have, would you want to ask that question or do you want to go ahead? Either way, I think you went to the slide already, so maybe you could go ahead.
Okay, sir. So the clinical diagnosis was acute stroke.
Yeah. Yes, Majas.
But it might be just at this point to summarize by the history, what are you presenting in terms of just what is
Yes,
the case? What do you think is happening, and what is the underlying etiology?
Yes. So this is a case of a middle-aged lady with no known previous comorbidities who presented with acute vascular event with left hemiparesis, left upper motor neuron facial paresis, and dysarthria. With the clinical examination,
Two-line summary.
yeah,
All
the clinical
this-
clinical examination showing features of atrial fibrillation with fast ventricular rate and features of rheumatic heart disease, especially rheumatic heart disease, mitral stenosis.
Right.
And the irregular heart rate is
Yes, atrial fibrillation with fast ventricular rate, likely to be a cardioembolic stroke.
So any past history of acute rheumatic fever?
No past history of acute rheumatic fever, no past history of any recurrent breathing difficulty or hospitalization for breathing difficulties.
Right. Okay, so you have an important clue clinically. There is a mid-diastolic murmur and there is a irregular pulse, irregular pulse, isn't it? Very important clue.
Yes, sir.
And carotids are palpable.
Cataracts are palpable and there were no bruise.
Where do you palpate internal carotid artery?
Sir, external carotid artery.
Where do you palpate for the internal carotid arteries? That's the classical teaching. All right, okay. You can do sometimes from the internal pharyngeal wall on the tonsillar fossa, or of course you could also look for bruise, etc. on the neck itself.
Yes.
Right, yeah, carry on.
So my clinical diagnosis was acute stroke with left hemiparesis, left upper motor neuron facial paresis and dysarthria and hemineglect, with localizing to right middle cerebral pulmonary artery stroke with an NIHS of 11, rheumatic valvular heart disease of mitral stenosis, atrial fibrillation with fast ventricular rate with the stroke mechanism likely being cardioembolic stroke. We activated the stroke protocol and she was rushed.
What else would have given you clues that it could be cardioembolism? You have, of course, fast heart rate, but in the general examination, on the what is the other clue usually for a cardioembolism?
Sir, to look for peripheral systemic emboli like splinter hemorrhages or any missing pulses or past history of any digital gangrene, and for fundus examination for any retinal hemorrhage.
Embolism to peripheral arteries, palpable peripheral arteries would be one clue. And of course, if that is complicated by endocarditis, you have to look for all the systemic signs of endocarditis as well, isn't it? Right. But there is no other suggestion. Okay.
No, sir.
Any clue regarding cardiac failure in this patient?
The jugular venous pulsation was not visible, and there was no basal crepitations at present.
And there was no generalized edema. Right. Okay. Please.
So we activated post-stroke protocol, and the patient underwent an emergency CT head with CT angio. This is the axial section of the plain CT, which shows a hyperdense MCA sign on the right side and a mild area of hypodensity in the right temporal lobe, and the aspect score was 8. The vascular imaging showed M2 occlusion, with the superior division of the MCA is not visible, whereas the inferior division of the MCA is visible. So the
Which part of MCA is blocked?
Superior division of the MCA.
No, 1, 2, 3, like that MCA segments.
Sir, M2, sir, M2 segments, M2 and M3 segments.
Right. Okay. From this picture, difficult to say M2 or M3, but yeah. Okay. Please go ahead.
The CT angio showed an hyperdense MCA with a short segment opacification of M2 and M3 branches of the right MCA. And also it showed an eccentric mixed plaque of maximum thickness of around 3.2 mm at the origin of the left subclavian artery.
Which you are not showing, right?
Yes, sir.
So do you think it's could be relevant to this? This is, it was just a finding on the.
Yes, sir. Final report.
Okay.
The ECG confirmed the presence of atrial fibrillation. Currently, it's showing a controlled ventricular rate. The blood investigations all were within normal limit, and the bleeding parameters were normal. Coming to the management, the relatives were advised for emergency IV
I'll
thrombolysis.
just ask, since the teaching session, I'll ask you one more question.
Yes.
In the toast category of the etiological classification of strokes,
Yes.
so it's more or less clear here. Which one would be your category? You already
Sir,
said that.
Yes, sir. Cardioembolic, the large vessel.
Okay. So what is the imaging clue which should help you to make that diagnosis? When do you classically, when do you think of a cardioembolism?
So when there is a cortical involvement, when there are multiple areas of
multiple vascular territories, maybe lesions of different ages, isn't
Yes.
it? These things will
Yes.
help that. That could be, but it may not be the case for the first time cardioembolism. But in a long-standing cardioembolic situation, that's an important clinic clue. It
Yes.
could be multiple vascular territories of different ages. Yes.
Relatives were advised on IV TPA and emergency DSA with mechanical thrombectomy. However, the relatives agreed only for TPA but refused for mechanical thrombectomy. IV thrombolysis was given with Actalize, and patient was transferred to stroke unit ICU for further monitoring and management.
So in your center, suppose a COVID positive case, here it was negative.
Yes,
if you are a TrueNet positive, what would you have done? Just say, don't elaborate, just what could have been your.
Sir, we would have still thrombolized the patient and shifted him to the COVID care ICU.
Yeah, I think the questions, what I suggest is when Majaz or me ask something, this is
Yes,
actually the other students also. So let them answer, and if they don't answer, you answer.
All right.
Right? Okay. So this is not a question answer between we and you, but interaction with students. So the students, you give them the chance first, and if they don't answer, you can answer. Right?
Yes.
Is that okay, Dr. Majaz?
Yeah, absolutely.
Yeah, just trying to highlight some teaching points. Right.
Absolutely.
Okay.
Shall I move on, sir?
Yes. Yes.
Emergency echo was done in the ICU, which showed severe mitral stenosis with mitral valve area of only 1.2 centimeter square and a dilated LA with an LA size of 4.2 centimeter and mildly reduced contractility of the LV with an LV ejection fraction of 45 to 50%. And in the LA appendage, echogenic contents were seen, were noted, which were likely to be thrombus.
Right. Okay. The LV size was normal, right? So basically a single. So what do the impression of the students on the cardiac status? Stroke neurologists should know a little bit about the cardiology, especially the conditions which are responsible for cardioembolism. So what are the things which you should look for in a patient with cardioembolism when you do echo? Can some of the students answer, please? Which will have a relevance in planning the management, long-term strategy, etc. If somebody like to take the question and answer, please. Otherwise, we are asking too many questions directly to Deepthi. Deepa.
Yes, sir.
Yes, please.
Sir, can you repeat the question?
So you have an echo.
Question is,
a patient whom we have found a mid-diastolic murmur, etc. And you have seen the echocardiogram. How do you, what all things you look for from the point of management of this patient? What all things you'll be interested in seeing? Are you just happy if you see a normal or what else? Yeah.
First we look at the LV
contractile function. In this patient, she has LV contractile dysfunction. And she also had mild LA size enlargement, and also there is a suspected thrombus inside the LA appendage. So,
Right.
So the question I think that he's asking you is a little different. He's asking you what, forget about this echo, but generally in echo, what would you look for in a patient with cardioembolic strokes? Am I correct, Doctor? Right?
Yes, yes.
Sir, we will look at first the LV contractile function to look for any LV motion abnormalities or any left ventricular thrombus or left atrial thrombus, and also left
And in a
atrial size.
young person, like this.
And in a patient suspected RHT case, we also look for any evidence of infective endocarditis and also PF.
No, if this was not a RHD case, a young person presenting with the cardioembolic stroke, what are the other things that you might be interested in?
We also look for patent foramen ovale.
So, good. Okay.
So what is that category of strokes called? A few things you specifically look for when there aren't any obvious lesions clinically in a young person. Yes. So can you tell me everything that you look for specifically in an ESUS? One is patent foramen ovale. What are the other things?
Sir, we also look at the aortic arch to look at any aortic arch plaque or thrombus there.
Anything else in the atrium?
In the artery, sir. In the artery,
in the atria.
Sir, LA size we will look for. In young patient, and we will also look for any myxoma.
Right. Okay. Yeah. So of course you have to look for all kind of congenital heart disease also. Some of them will be having right left shunts also, isn't it? But it's easier to have strokes, but of course we expect strokes, etc. at a much younger age, and there will be other signs like cyanosis, etc. But to complete the full picture of cardioembolic stroke, that's also a very important category, isn't it? Right. Okay. We have to cover many things, so please go ahead.
Yes. So cardiology consult was taken for optimization of the cardiac status, where she was advised rate control drugs with diuretics, ACE inhibitors, and plan for anticoagulation. Now, coming to 24 hours post thrombolysis, there was no further neurological worsening, and NIHs remained 11. And the repeat MRI scan, which was done 24 hours post thrombolysis, showed a moderate size infarct involving the right frontoparietal region and a bit of temporal and a part of right temporal lobe. And there was no.
Do you want to say the sequence that you are using?
So this is DWI axial sequence.
Let the other students say which are each of these sequences very quickly. You can ask which is the sequence. If they don't tell you, tell quickly.
What is the MRI sequence?
The diffusion MRI.
Yes, axial.
Diffusion weighted imaging.
And here?
This is an ADC. What is an ADC? Apparent diffusion coefficient.
Okay, so you have got both of them, isn't it? Which one is more sensitive to detect the core infarct? More sensitive.
Diffusion rate.
And more specific. Why do we do both?
So, if there is a diffusion restriction and there is no reversal on ADC, it will indicate T2 shine through.
Right. Okay. Yeah. So please go ahead.
This is the flare, T2 axial flare section.
Sorry to interrupt. Majaz, you also have any questions?
So this is the T2 axial flare sections, which is showing an established infarct in the right frontoparietal-temporal region, and this is the susceptibility weighted imaging sequence, SWI sequence, the MRI brain, which does not show any hemorrhagic transformation post thrombolysis. However, we can still see the right-sided M2 thrombus, which was initially seen as a hyperdense MCA on the CT at the baseline image. Now we come to the day 14 since stroke. Since this was a high risk cardiac lesion, being a severe mitral stenosis with a dilated LA size of 4.2 centimeter with atrial fibrillation and a LA appendage clot. So this is a patient who was a candidate for anticoagulation. So according to the guidelines, we had repeated CT at day 14, which did not show any hemorrhagic transformation. And the patient was initiated on oral anticoagulant, which is a vitamin K antagonist, acetrom 2 mg, which was overlapped with Clexane 60 mg subcut BD to achieve a target INR of 2 to 3. And 48 hours after oral anticoagulation initiation, INR was 1.64. On day 17, since stroke, the family requested discharge. Repeat echo done on the same day did not show any LA appendage clot, and she was discharged on acetrom 2 mg OD. The cardiac medications were optimized, anticoagulation education, and home physiotherapy regimen was given.
I have a quick question here. Did
Yes,
you
sir.
discharge the patient on a fixed dose of the acetrom?
Yes, sir. The
Was the
patient was
patient
discharged. The
on a
patient was
fixed dose, right?
Yes, sir. The patient was discharged on acetrom of 2 mg OD and was advised to follow up 3 days later with the repeat INRs.
So there are two issues here that come up. The first, of course, is that you know that IV TPA was not going to work here very well. This is a large vessel occlusion,
Yes, sir.
proximal M1 actually, it's not M2. So the chances of this working with IV TPA is very small.
Yes, sir.
The second, so one should have been more consistent with trying to push the family into a thrombectomy, which would have actually helped improve the outcome. But the second part of it is that you have to be very careful about Coumadin or acetrom management with such a large infarct in terms of follow-up, because unless you have very, very close INR follow-ups, you might end up with a very bad consequence. So this might just two take-home points. You can move on, of course.
Yes. She presented to us 48 hours after discharge with a history of severe headache for 1 day and altered sensorium 2 to 3 hours prior to presentation. There was no history of any seizures or fall. The GCS was 14/15 and heart rate was 172, which was irregular, BP of 160/90. CNS examination showed equal bilaterally reacting pupils with bilateral ptosis, left UMN facial paresis as before, dysarthria. Tone was reduced on the left upper limb and lower limb. Power on the left upper limb was 0/5 and left lower limb was 1/5 with bilateral plantar extensor response. Diagnosis.
What do you think has happened at this point? Anybody? Take a guess. Any of the students would care to answer the question? And the clue is that you have bilateral plantar extensors, you have altered sensorium, you have severe headaches, worsening of a previous deficit. What do you think has happened?
Maybe there are more than one logged in systems in your room.
Yes, sir.
Yeah.
So this patient, after discharge, she developed severe headache and presented with altered sensorium. So I do suspect, since the patient was on anticoagulation, either a hemorrhagic transformation.
And also think about the fact that now there's bilateral plantar extensors. Initially there was one left plantar was extensor, now it's bilateral. What does that imply?
There's bilateral ptosis.
Yeah, bilateral ptosis, bilateral plantar extensors.
So there will possibility of raised ICP because of the hemorrhagic transformation and herniation, or another possibility is a fresh stroke.
Which seems less likely given the fact that you're a person on anticoagulation, well, at this point, well anticoagulated. So if you think about the two possibilities, the possibility of a hemorrhagic transformation with mass effect compromising the contralateral hemisphere is more likely, right?
Yes.
You use the word hemorrhagic transformation up to how many days? When you say it's a fresh bleed or a hemorrhagic transformation, is there any cutoffs, classical description? You tell, otherwise we can progress, but think about it. I think we could probably go ahead with the next slides because we are running only 3 minutes or 4 minutes. It's showing.
Okay, sir. So the clinical diagnosis at this point was intracerebral hemorrhage or an subarachnoid hemorrhage, likely to be anticoagulant induced, and with the recent ischemic stroke with an MRS of 5 and rheumatic valvular heart disease with severe mitral stenosis and atrial fibrillation with fast ventricular rate. She was rushed for an emergency CT head, and this is the axial section of the plain CT, which shows in the area of the previous infarct multiple large bleed with fluid levels and variegated appearance of various hypodensity, classical of that of an anticoagulant induced bleed with mass effect and significant midline show.
That's an important point actually. If you see this, the fluid and level, that's actually a point a little bit in favor of a anticoagulant-induced bleeding because it continues to remain without clotting there, and that's why this layering is also continuing. So that's a point generally set in favor of an anticoagulation-induced bleeding. Please continue.
Her emergency investigation had shown deranged prothrombin time of 33.3 and an INR of 4.51. She was immediately rushed to our stroke unit ICU, where vitamin K and 15 ml per kg fresh frozen plasmas were given. Emergency neurosurgery consult was taken, and she was advised decompressive clinectomy.
The INR 4.51 and PT 33.3, they are simultaneous. Is the same reading or different reading?
Same readings, control.
Usually the INR ratio, what will come? What will you get the INR ratio here? 33:12. So what did you calculate the 4.51 here?
33.2.
Okay. Yeah, I think. I'll just look into that and we'll continue.
Time is a little short.
Yeah.
So
Okay.
on 6th of July, she underwent a right frontotemporoparietal decompressive clinectomy with bone flap in the right anterior abdominal wall. And on 28th July, she was discharged in MRS stage.
Right. Dr. Majas, you can, it's only very limited time only, so please ask.
Just to summarize this, I think the case should have been addressed with more aggressively with the aim to thrombectomy in this particular case, because we knew the chances of this happening is bad. The second part of it is that this was always a risk, and you didn't have much of a choice. The risk, the anticoagulation that you had to do early on was only because of the auricular clot, which is not such a high risk as the apical clot. So if you had an apical thrombus, that's where you would have definitely been compelled to do anticoagulation to prevent a second cardioembolic stroke. This was a little lower risk, but anyway, it was done. The patient now is left with a reasonable quality of life, I believe, because it's the right hemisphere. You've been able to save the left hemisphere, and the question is now rehabilitation.
So, despite following guidelines that at day 14 she was started on anticoagulation, and the anticoagulation is acetone is the only form of anticoagulation according to the guidelines at present for the moderate to severe stenosis. So, despite following the guidelines also and being a large stroke on day 14, the patient did have a anticoagulant induced
Thank you, Dr. Deepthi.
I have a question, just last one point. Do you think there is a case for precision medicine, that is any pharmacogenetic tests before, because the dose you are given is just 2 mg, still we ended up with an INR above 4. Do you think, and what are the genes which are important in relevant to this oral anticoagulations?
Vitamin K dependent factors 2, 7, 9, 10, the genes responsible.
You got CYP2C9 and also the VK ORC subunit 1, 2 genes are important, isn't it? So in those who are having this polymorphism, you may have to do, there is actually some, I think in US FDA has a warning on this, some of these medications. Dr. Muniz, what's US guideline right now?
So we don't routinely test,
Right.
For Coumadin, but
Right.
in specific patients, yes.
Yeah. So
Can I make one final comment?
Sure.
Yeah. So in an ideal situation, in India, that is an issue. If you're in a government center where MD is supported, you offer and they just take it up. But in private setups like us, where post-COVID, we are seeing a lot more people who can't afford even IVT. So that was a dilemma, and in an ideal situation, of course, a mechanical thrombectomy is the best option. But there are many, particularly these type of clots, they also have some recanalization with IVT. So that's why they opted for IVT. So that is one thing. Second is that 14 days, it's again an arbitrary, day, even though guidelines say that, but still we don't have a clear answer when to exactly start. It's probably for atrial fibrillation that the trial, that few trials are ongoing, like ECLAN and few other trials, which will answer the question, based on the size of infarct and starting the patients on anticoagulation. Thank you.
Thank you, sir.